Hello everyone, my name is Isaac Mitchell and my presentation is on medical fat phobia and negative health outcomes. My research question was, how does fat phobia in the medical field impact the health outcomes of fat patients? Before we get started, I'd like to go over some basic terminology just so we're all on the same page, because I know that some of these phrases, people might be unfamiliar with. Fat phobia, despite the name that might imply that it is a fear of fat people, it is negative attitudes, behavior, and discrimination towards people based on their bodies being fat. And you might also hear it called weight bias, weight discrimination, anti-fatness, things like that. This can also include a strong preference for thin people over fat people. And this occurs often in hiring practices and medical care and other places in society. Health at every size, also known as HAES or HAES, is a healthcare principle that de-emphasizes weight, BMI, and weight loss in favor of holistic health regardless of weight. The origins of the modern-day body positivity movement, as well as health at every size, can be traced back to fat liberation, which was a political and social justice movement started in the 1960s with the goal of fighting weight stigma in healthcare, hiring practices, beauty standards, and society as a whole. It's a common misconception that the idea that fat people are mistreated or deserve to be treated better in society is a new idea, especially with body positivity and things like that being big on social media, but it does have its roots much earlier than that. And also, I will be trying to use the term fat as much as I can versus obese or overweight, just because that's the terminology that a lot of fat activists prefer, as obese and overweight are considered stigmatizing and rude. So while at first it might be uncomfortable to hear me saying the word fat instead of those terms, just know that that's the reason why. The motivation for this topic is twofold: the relevance to healthcare professionals as well as the relevance to healthcare economy. I myself am going into nursing, so I relate more to the healthcare professional side of it. And as a healthcare professional, future healthcare professional, I have a duty to provide patients with ethical care. Healthcare workers also have a responsibility to not make decisions based on personal biases. And I was interested in understanding more fully and shedding some more light on the unintended impacts of personal biases in the healthcare space. For healthcare economists, it's important to evaluate the ethics and effectiveness of current care models. Current models of care for fat patients often include weight loss as a priority over other health issues. And it's important to evaluate the ethics and effectiveness of that and to know how well current healthcare models are working to help improve patients' health. There's also this idea in the healthcare economy space that fatness costs a lot of money, that overweight patients are costing the whole system a lot of money, and skinny patients deserve to not be paying for that treatment. The phrase I'm using for this is the healthcare cost of obesity, and I will be touching on it in a minute. The first part of my research question that I want to tackle is, do healthcare workers have a prejudice against fat people? In the 2012 study, Implicit and Explicit Anti-Fat Bias Among a Large Sample of Medical Doctors by BMI, Race, Ethnicity, and Gender, researchers used an implicit association test to determine if test takers had a preference for thin or fat people. The researchers concluded, based on the results from the study, that the general population holds strong implicit and explicit anti-fat bias. They also found that medical doctors, on average, also showed strong implicit anti-fat bias. The anti-fat bias level found on the test was similar across demographics, across age and weight, except for test takers who were fat, and they had a less strong anti-fat bias. Now, one problem with this study is that it is self-administered and self-reported demographics. So you take the online test, you take the first portion, which is the implicit bias test, and then it asks you explicitly, do you prefer skinny people or fat people? And do you identify more with skinny people and fat people? That sort of thing. So that's the explicit portion. And it also takes your demographics, your career, your age, your location. So this was looking at the people who said that their job was medical doctors, but it wasn't confirmed because it's an online self-reported test. So that does impact the reliability of the test in some ways. They also reported that all test takers reported strong explicit preferences for thin people over fat people on average. Overall, this study does a good job of demonstrating evidence for anti-fat bias among healthcare professionals. I would say that more research on how these biases impact people's behavior would be beneficial. The second study that I looked at that examined fat phobia in healthcare workers was Examining Weight Bias Among Practicing Canadian Family Physicians from 2019. This was a survey of 400 Canadian medical doctors. They were given a list of statements and they were asked to respond agree, neutral, or disagree. These are some of the results from the questions. 24% said that they would not be comfortable having a fat friend in their friend group. 18.5% agreed with the statement, I feel disgust when treating a patient with obesity. 22.5% disagreed with the statement, I like people with obesity. 46% disagreed with the statement, treating patients with obesity is professionally rewarding. Although this study does have a relatively small sample size, and as always, the wording of questions can really impact the way people answer, I do think that this is some good evidence, again, to show that there is fat phobia in the healthcare space, and that many medical workers do have negative bias towards fat people. Again, both of these articles are looking into personal opinions and preferences and biases, and not necessarily behavior. And again, I think that more research should be done to look into the correlation between fat-phobic mindsets and biases and actual mistreatment of fat people. In the conclusion to the survey of Canadian healthcare workers, the authors wrote, this study emphasizes the need to reduce weight bias among practicing physicians in addition to making efforts to sensitize students entering the medical profession. Without such initiatives, patients with obesity may continue to experience harmful effects of weight bias, including less respect, less time spent with patients, and less patient-centered communication, thus contributing to negative effects on their overall health. Those negative impacts on overall health are exactly what I want to focus on next. The 2022 article, Associations Between Weight Discrimination and Metabolic Health, a cross-sectional analysis of middle-aged adults, examined the correlations between metabolic health issues and weight discrimination, and they found significant correlations between the two. Health records and metabolic panels of subjects was compared to self-reported experiences of weight discrimination with different levels of severity. Subjects who reported experiencing weight discrimination had an 85% higher likelihood of having diabetes as well as some other metabolic issues. This article determined that weight discrimination may negatively impact metabolic health due to stress caused by the discrimination. However, the results of this study were more correlational and not causational, and they determined that more research was required about the causes of the negatively impacted metabolic health. Another similar study, The Role of Stress in Health Behavior and Linking Weight Discrimination and Health, a secondary data analysis in England from 2023, also found a correlation between weight discrimination and higher stress levels. They used a hair cortisol test to determine this. A hair cortisol test is where you take a strand of hair from a patient and use it to test cortisol levels over time. Cortisol is your body's stress hormone and it regulates your body's responses to stress. So higher levels of cortisol usually means higher levels of stress. And the conclusion that they came to was that weight discrimination was negatively impacting patients' stress levels. Next, I want to circle back around to what I mentioned earlier of the healthcare cost of obesity. There's a widely held assumption that because people with a higher BMI tend to spend more on health insurance, losing weight will lower a patient's healthcare costs. Because of this, assumed healthcare costs are a driving factor for promoting weight loss as a treatment. I want to focus on one study that supports this idea and bring up some issues I have with it. This study is from 2015, and it is titled Savings in Medical Expenditures Associated with Reductions in Body Mass Index Among U.S. Adults with Obesity by Diabetes Status. This study concluded that weight loss would decrease medical spending. This graph is from the paper. The x-axis is BMI, and the y-axis is total expenditures in dollars. The solid black line shows the correlation between increased BMI and increased healthcare expenditure for patients without diabetes, and the dotted line is the same for patients with diabetes. The gray lines are the confidence intervals, upper and lower bounds. As you can see on this graph, there is a correlation between having a higher BMI and having higher healthcare costs. However, since correlation does not equal causation, this doesn't necessarily mean that losing X amount of weight will result in your total healthcare expenditures lowering X amount. The authors of this article estimated that fatness cost the U.S. healthcare system $315.8 billion in 2010. But in my opinion, they failed to bring significant evidence that on an individual level, lowering your BMI will lower your healthcare costs. I also believe that they have misrepresented some of their key sources. For example, they make the claim that clinical research has established that a sustained weight loss in obese individuals has significant health benefits. This is a key claim to their point that losing weight will not only reduce reduce total healthcare costs, but it will also be beneficial to patients. One of the sources for this statement is the 2002 article, Reduction in the Incidence of Type 2 Diabetes with Lifestyle Intervention or Metformin. In that study, they gave patients who had an increased risk of diabetes different treatments, including placebo, the medication metformin, as well as a, quote, lifestyle modification program with the goals of at least a 7% weight loss and at least 150 minutes of physical activity per week. As you can tell, weight loss was not the only factor that these patients were given to treat the potential diabetes. And later in the article, they say, quote, our lifestyle intervention was systematic and intensive, with the study participants receiving detailed, individualized counseling. The study, however, was not designed to test the relative contributions of dietary changes, increased physical activity, and weight loss to the reduction in the risk of diabetes, and the effects of these components remain to be determined. As I said earlier, this article is highly cited as proof of the financial cost of fatness. My main issue with this article is that it was funded by Novo Nordisk. They are a pharmaceutical company that manufactures weight loss drugs Wegovy, Saxenda, and a new experimental weight loss drug that they are looking to release soon called amycretin. All the authors of the article are employees and shareholders of this company. Personally, I believe that the fact that these people work for a company and have a personal financial interest in the success of multiple weight loss drugs means that they have a significant conflict of interest. Finally, I would like to touch on health at every size, which, as I said before, is an approach to healthcare that de-emphasizes weight and dieting and weight loss and emphasizes holistic health, as well as increasing self-esteem. The 2012 meta-analysis by Lindo Bacon, Weight Science, Evaluating the Evidence for a Paradigm Shift, is an important piece of work in the history of the health at every size approach to healthcare. In this article, the author determines that weight is not a great marker for determining health. They also came to the conclusion that, similar to the example of the study that showed decreased amounts of diabetes in people with lifestyle changes, this article determined that many health benefits that are commonly attributed to weight loss can actually be attributed to the lifestyle changes that would result in that weight loss. For example, if you start exercising every week and you lose weight as a result, this author concludes that it is the lifestyle change of exercising more regularly that would cause your metabolic health to be benefited, as opposed to the actual weight loss and the numerical pounds lost. Another piece of evidence that they have for this claim, that weight loss itself is not inherently beneficial, was a study where they gave patients liposuction with no lifestyle changes and found that it did not significantly impact their health markers. They concluded from this that weight loss on its own is not exclusively beneficial and can often be harmful, and that weight loss should not be a one-size-fits-all prescription. Some of the conclusions that we can draw from this research is that weight discrimination is harmful and widespread, including in the healthcare field. Another takeaway is that the link between weight and health isn't as clear-cut as it seems. The common basic idea that fat people are unhealthy, skinny people are healthy, doesn't necessarily hold water. There are many variables other than weight that impact health, including lifestyle, socioeconomic factors, and the amount of discrimination that you face. For healthcare workers and healthcare economists, addressing your personal biases about fat people is valuable. It can help you make more informed decisions and just be a kinder person overall. Fat people deserve quality healthcare as well as equal treatment in the healthcare space and everywhere else in society. Thank you so much for listening to my presentation.